much, Dr. Khalid. Now, please welcome with me Dr. Haifa Alotaibi. Dr. Haifa is Acting Deputy Director, Scientific Research Center.
I think we cannot see it here. طيب معرفة فاطمة. I think it's not shown here my طيب ما في مشكلة it's fine. It's fine طيب. الله يعطيكم العافية جميعا. I know it's already late at the end of the day and my topic is kind of hectic, but I will try to keep it simple. I'll minimize my talk as much as I can. Today, inshallah, I'm going to talk about clinical practice guideline, the process of development of clinical practice guideline, and how you will assess the credibility of the guideline in general and recommendation. I'll try as much as I can to keep my talk interactive so everyone will benefit from it. How to move? Okay. First of all, just to know how I'm going to tailor my talk, how many have been participated in clinical practice guideline previously? If I can see hands, please. Okay, Fatma, you know. So I think I can say whatever I want to say. Dr. Hajar is part of our guidelines. طبعا أنا member مع Ministry of Health في multiple guidelines we are working on currently. طيب. I'll use an example was shared يمكن في الليكتشر تبع دكتور وليد الهزاني before. عشان بس just to keep the practical session أكثر من إنه theoretical. Let's say that you are working on a guideline about GI prophylaxis in ICU patients, okay? And you're thinking which is better to use H2 receptor antagonists or PPIs. One easy option, a group of experts sitting together, everyone is sharing his experience, his selected, خلينا نقول selective evidence that he's aware of, and give his opinion, and at the end of the day they will claim that it's a recommendation, okay? Or they may use a more structured way that all of us are aware of, which is a developing of clinical practice guideline. Let's say that you decide that you decide that you want to work and develop a clinical practice guideline. What are the structure that you need to think of? An organized way of thinking. First of all, who are the people that will be involved in your guideline? You need to define who is your clinical chair, who is your method chair, a group of methodologists that need to be involved with a task معينة حنتكلم عنها later on. Who are your panel members, طبعا clinical experts اللي حيكونون معك. Systematic review team consisted of a librarian that will do the search, a reviewer who will select the study and extract the data, a statistician sometimes needed if you have an outdated systematic review and you need to update it. You need a statistician to help you in that. Last and definitely not least, you need a conflict of interest adjudication committee who are responsible of reviewing, managing any possible conflict of interest that may rise in any panel member. After you define the manpower of your guideline, you need to decide what is the scope of your guideline, okay? And after deciding about the scope, what are the topics that need to be covered under this scope? Who are the target end users? What's the deadline for the guideline in general and each step in the development of the guideline, and if there is any financial support and resources. This is a nice checklist. I would recommend anyone who is interested in guideline development to read. one important aspect before starting any guideline you need always to think about how to manage any possible conflict of interest. And when we say conflict of interest, mainly we are talking about what? Three possible conflict of interest. The most important and most common type is a financial conflict of interest, where the panel member or the author have financial interest that influences decision when he formulate the recommendation. Intellectual, which is always not addressed, where like خلينا نقول الauthor أو الpanel عنده commitment to a specific research theory أو research method that influences decision. Professional, like a professional position or affiliation that keep the panel member deviated from a specific decision. What is the possible approach? How we address the conflict of interest? Ignore, طبعا, which is the worst way in dealing with any conflict of interest. Declare. أي guideline نبدأ نعمل فيها, the first step is to ask all the panel members to declare any possible conflict of interest. Is this enough? Actually, no. If they declare it, we have two possible ways in dealing with the conflict of interest. Either forbid the member from participating in the guideline as a strict way in dealing with a conflict of interest, or manage. Manage either to balance involving him while taking the risk of deviating a recommendation that will be developed, or selectively forbidding him from participating from a recommendation that he's conflicted with, and so on. So هذه أول step, conflict of interest management. طبعا في أغلب يمكن الارticles اللي passed by any one of you, they always talk about financial, positional conflict of interest. However, intellectual conflict of interest usually not addressed, okay? And it's a very important part to think about. Now I'll try as much as I can to pass by in a practical way the steps of developing any clinical practice guideline. طبعا احنا already we defined the scope, we defined the topics. Now you will start by formulating question. After you formulate the question in a PICO format, I'll talk about each step of this in a minute, but I'll pass by them quickly now. Select all the outcomes that you are interested in your PICO question. Then you'll ask the panel member to rate their importance in something called outcome prioritization. You'll do the search, you get a systematic review. The best طبعا انك تاخذ systematic review of well-designed RCT. Then you will fill something called evidence profile, which include two aspects, quality of evidence and pooled estimate of the result. This will allow you to rate the overall quality of evidence across studies from high to very low. Then you'll ask the guideline panel member to formulate the recommendation for or against an action, and they need to define the strength of the recommendation, either strong or conditional, and they need to consider not only the evidence that you get, actually value and preference of the patient, resources, and other aspects. I'll discuss it in a minute. We have a specific wording usually we like to use in our guidelines that we use. We recommend when we state a strong recommendation and clinicians should follow this recommendation. We suggest if a clinician might, which is a conditional or weak recommendation, okay? Try as much as you can to keep it transparent, clear, implication of action, and unambiguous. So I'll start by all these steps one by one. First of all, question formulation. A very important step in any guideline development should be clear, comprehensive, actionable. The intervention and the alternative, again, should be clear. We'll use the PICO format, I believe everyone is aware of, where you define your population, your intervention, the comparator, and outcome or outcomes. I'll give you an example. When we develop usually our guideline, we need to define our PICO question. First, we state it in a statement like this. For example, I'll follow this example among my all presentation. In adult mechanically ventilated ICU patient, my population, should we recommend PPIs, my intervention, over H2 receptor agonist for GI bleeding prophylaxis, okay? Later on, there is a table where you need to explicitly define all the aspects, okay? Your population, your intervention, your comparator, and all the outcomes. And you can notice that here when I say PPI in my question, in my table, I need to define what type, the dose, the route, and the frequency. Same for H2 receptor agonist. And all the possible outcomes that you think that you are interested in, you need to put it here. Already I formulate my question. I selected the outcomes as I show you. Now I'll go to a very important step called rate importance or outcome prioritization, where a survey will be sent to all panel members and they need to rate the outcomes in a scale from 1 to 9, okay? We try as much as we can to keep our outcomes from 5 to 7 and not exceeding 7. The outcome should be related to the intervention. And when I say critical, I mean critical for patient and for decision making. As I mentioned, the rate on a scale from 1 to 9. So something similar than this will appear for you. If the outcome receive a rate from 6 and above, we will define it as a critical outcome, And from 3 to 6, important outcome. Below 3 is a not important outcome. Now I finish. I have my question. I define my outcomes, and I rate their importance. I'll go and did a search in the literature, and most probably you will get طبعا the best انك تلاقي updated systematic review of a well-designed RCT, okay, which is the current best evidence. For my question, let's say that I identify actually this خلينا نقول systematic review and meta-analysis of randomized trial. It was an updated evidence at that time. I believe today Prof. Farid explained about a forest plot. عادة when we get the systematic review and we would like to extract the data, we depend mainly on the forest plot, okay? So this is forest plot. I'll pass by it quickly. At the first column, you have the name of the study, then you have the number of events to the total in your intervention, the number of events to the total in your comparator, the weight of each study, and the estimate for each study, then the year. These lines represent the confidence interval and the point estimate in each study. The box represents the point estimate. When the box is large, that means the study have a high weight with a large sample size usually. And when it's small, that means it's a small weight of the study. And even the خلينا نقول effect of this study on your summary estimate is less. The diamond at the bottom represent your point estimate, the summarized estimate. So now, which is a very important step for any methodologist who will be involved in a guideline later on in the future, they need to fill something called evidence profile. This evidence profile will depend on the systematic review that you get. I mentioned before that the evidence profile fill two important aspects. First is the quality of evidence for each outcome, not for each pick a question. For each outcome, you need to fill the quality of evidence, and then the summary of the result, which will have the pooled estimate of effect for each outcome. When I say quality of evidence, it means it should be comprehensive and explicit and should be done per outcome, not per pick a question. What does quality of evidence mean? When I say I'm filling now the quality of evidence, for what reason? Why I need that? It helps you in what important part? It tells you how much you are certain, how much you are confident regarding this evidence. I'm going to put it for my panel expert to decide and give a recommendation, how much I'm certain, how much I'm confident. That's what a quality of evidence means. And again, I repeat myself, it should be done at an outcome level. Judgment should be transparent. At the end of the day, if you decide to publish this manuscript, you need to put it in supplementary. The evidence profile should be available for anyone who want to question, like later on you formulate your recommendation based on what? And it should be assessed based on four important domains. First of all, the design and execution of study, which talk about risk of bias. Second is heterogeneity or inconsistency between the study, which is the difference between the result of this study. Similarities between included study and pick a question, which we call indirectness. Fourth is the precision of the estimate, and other aspects like application bias. What I just explained now in the quality of evidence assessment, we call it grade approach, okay, which is grading of recommendation assessment, development and evaluation. طبعا هذا well known system يستخدم في guideline development for quality of evidence assessment and the strength of the recommendation. طيب, let's go now to the quality of evidence. I'll try to minimize my talk here. Maybe Dr. Walid touch some parts of this. Let's say our systematic review, the one we get it was a systematic review of what? Of randomized control trial. Okay, by default, an RCT will start as high quality of evidence, and an observational study, you will start as a low quality of evidence. Okay, this is your beginning. So again, for the طبعا بالنسبة لسؤالنا كان ال outcome clinically important GI bleeding. We mentioned that for بالنسبة للدراسة حقتنا design أغلب دراسة في systematic review هذه كانت randomized control trial. So now زي ما قلنا بدأنا high, and we need to assess all the domains that we discuss to see I'm going to rate down or no. I'll start by risk of bias. طبعا لما أتكلم عن risk of bias أتكلم عن design and execution. What I want to know is there is a serious risk of bias that may lower my confidence in the estimate. عادة في أي systematic review or meta-analysis you'll find something similar to this. ما راح أتكلم عنه بشكل مفصل, ولكن بتشوف كل دراسة معمولها risk of bias assessment. Okay? In our systematic review, I can see that Conrad and the other two only have low risk of bias, while the other either unclear risk of bias or high risk of bias. Okay, so when I look to my forest plot, I notice that these three studies have almost 60% effect or more weight on my estimate. In similar scenario, what should you do? You did something called subgroup analysis, okay, where you divide the study according to the risk of bias. And when I look to the result here, you can see that the diamond at the top, which is the one with the high risk of bias, show clear benefit and favor the PPI, while the one with low risk of bias barely beneficial to cross the line of no effect. And you look down to the bottom, something called test for subgroup differences, which is test for interaction. I can see that it's statistically significant. What does that say? It says that there is statistically significant difference between both groups. And so later on we decide to downgrade one step for risk of bias. And there is clear that the risk of bias affecting my result. I'll go to the next. Imprecision. Imprecision عادة نحكم عليها بناء على إيش؟ أول شيء, what does imprecision mean? Okay, imprecision معناها إنه how much you are confident or certain regarding the estimate of the effect size اللي أمامك هذا, how much you are certain that it's precise. Okay, how usually we assess this? طبعا أنا أتكلم حاليا in a meta-analysis. Okay, how am I usually people assess the imprecision in a meta-analysis? Confidence interval is definitely one of the ways. طبعا أتوقع هذه the easiest. If you have a wide confidence interval that cross the line of no effect, we downgrade one step for imprecision. Another statistical analysis. Okay, I believe, look at this now. طبعا هنا لو بنشوف بالنسبة our example, I can see that the point estimate is narrow and not crossing a line of no effect. If I'm going just to follow the confidence interval, I'll not downgrade for imprecision. However, I did some calculation here. طبعا I'll inform you why I did it. Usually عادة احنا نعتمد على baseline, على absolute evidence, ما نعتمد على relative. Relative sometimes overinflate the result. Okay, so here I calculate the baseline risk for the clinically important bleeding. The baseline تبعي هو تبع الcontrol, which is the H2 receptor agonist, 6.5%, and I calculate for the intervention, which was 2.3%. I calculate something called the risk difference, and I get to it is like 4.1%, or in a more practical way, 41 fewer clinical important bleeding per 1,000. Okay, and when I add the confidence interval, I can say that 41 fewer GI bleed per 1,000, ranging from 21 to 52. Now the important aspect that I need you all to be aware of. عادة في أي outcome نحتاج الclinical expert to define or decide about threshold, clinical decision threshold that we will depend on. Let's say that my panel expert decide that 2% is their clinical decision threshold. Okay, so I will not downgrade for imprecision because my estimate and the confidence interval did not reach the 2%. However, let's say that my panel decided that it's 3%. I'll downgrade for imprecision because there is a chance that the true effect will fall less than 3%, okay? And this is what happened in our guideline. Our panel expert decided that 3%, so I downgrade for imprecision. The third aspect that you need to look at always when we talk about imprecision is number of events, okay? بشكل roughly, I'll not go more than this, لكن في طرق معينة more يعني خلينا نقول sophisticated. Usually they said the number of events should exceed 100 to 150, okay, to detect the outcome. I'll not go through this, it's kind of complicated and I believe شوي صعب يعني. Okay, so for let's back to our question. I downgrade for imprecision because the number of events was less, okay? I'll go to the next, which is inconsistency or heterogeneity. Anyone have an idea what heterogeneity is? بشكل practical يعني, when we say in the meta-analysis we have a number of studies, when we talk about inconsistency or heterogeneity, it means that there is difference between the study and the result of the study because of whatever reason. Clinical difference, مثلا هذه pediatric وهذه adult. Methodological difference, هذه observational وهذه RCT. أو statistical difference for whatever reason. However, طبعا أهم شيء أنتم بالنسبة لكم إنه there is inconsistency between the study, heterogeneity, yes or no. And it's usually assessed in three important tests. Visually, look to the confidence interval. If you can see an overlap between the confidence interval of all the study, okay. I'll go to the next second اللي هو طبعا something called chi-square test, which is a test of heterogeneity. If it is statistically significant, I'll downgrade for heterogeneity or inconsistency. And the I-square give you طبعا هو proportion أو degree of heterogeneity in the study. وفي لها طبعا قيم معينة ذكرها دكتور وليد اليوم. In general, if it's above 50%, I'll downgrade for inconsistency or heterogeneity. طبعا back to my بالنسبة لنا I-square is 0%, the p-value is above 0.05. So طبعا confidence interval there is clear overlap, so I'll not downgrade for inconsistency, okay? Another aspect, هل في أي subgroup differences you notice it? هل هي trustworthy? هل تستاهل إنه أعطي different recommendation for this specific subgroup, yes or no? This is another aspect يعني always consider it, okay? Again, back to my example, ركزوا أنا بدأت في RCT as a high quality of evidence and I downgrade two steps because of possible risk of bias and imprecision. Indirectness concept سهل. هل ال question تبعك والevidence addressing the same thing ولا لا؟ يعني مثلا أنا I'm talking about adults admitted in the ICU mechanically ventilated and what I get from the literature طبعا evidence اللي طلعتها كان population مثلا pediatric, okay? So I'll downgrade for indirectness. هذا one aspect. Intervention أنا I'm talking about PPI. The evidence that I get something different and so on. So بالنسبة لنا clearly evidence اللي طلعناه addressing the same. Population, intervention and comparison and outcome, okay? فهو بس هذا just example for you. I will not downgrade for indirectness. آخر نقطة هي طبعاً other consideration. الدكتور اليوم تكلم على something called publication bias where you are not sure, okay? هل كل الدراسات نشرت yes or no؟ في لها أكثر من طريقة في الأسسمنت either visual using something called inverted funnel plot, okay? المفروض أن الدراسات تكون في الفانل بلوت متوزعة بشكل symmetrical to the right and left of this line, okay? Small study will be scattered down of this graph. Large and precise study will be scattered at the top. طبعا if there is a gap in the funnel plot, there is a possibility of publication bias. However, in our study we didn't downgrade for publication bias, okay? I end. الحين خلصت. طبعا في evidence profile you'll find something like this, okay? أنت بتعبي risk of bias, inconsistency, indirectness, imprecision and other consideration with summary of estimate on the right side. Automatically the quality of evidence will be calculated. Here it will be calculated as low, okay? زي ما احنا عملنا قبل شوي we downgrade two steps. Is this enough؟ طبعا لكل زي ما قلت لكم the quality of evidence for each outcome. All the outcomes that I list have been dropped here and we do the same. نفس اللي عملناه في clinically important bleeding we did it for all the other outcomes. طيب نقطة مهمة الحين أنا بالquestion هذا what the quality of evidence that I'll give? I'll give it low, moderate, very low. Rule of thumb, the total أو overall quality of evidence should not be higher than the lowest quality of evidence. هنا طبعا بالنسبة للسي ديفيسل كان مو واضح كان very low and that's why what did we do؟ إيش عملنا؟ أعطينا ال overall very low quality of evidence. okay? بالنسبة لهذا السؤال تمام؟ طيب أنا الحين I finish خلينا نقول I fill my evidence profile table. I have the overall quality of evidence. What is the next step؟ إيش لازم أعمل؟ طبعا من اللي يعمل؟ أنا لما أقول did أو fill ال overall quality of evidence who usually did this step؟ methodologists. okay? الحين I'll go to the stage where the panel members اللي هم ال clinical experts will be involved. okay? أنا بعطيهم التابل هذا. okay? And I'll ask them to formulate recommendation. طيب when they formulate the recommendation they will depend only on my quality of evidence table. What do you think? طبعا they need to look to many other aspects. okay? طبعا بالgrade approach واضعينها لك في grade pro system. They need to pass all these steps من ضمنها patient value and preference من ضمنها cost, feasibility, acceptability, many aspects that will help the panel member to formulate the recommendation. okay? طبعا هذا خلينا نقول الستيب اللي يصير فيها conflict يصير فيها مشاكل احنا عادة نضع threshold معين للvoting after formulating the recommendation and so on. طيب خلينا go to the okay. زي ما تكلمنا انه خلاص انا الحين عبينا ال quality of evidence أو evidence profile table and I give the clinical expert أو panel member to formulate the recommendation. من النقاط اللي مهمة بالنسبة لهم patient value and preference. okay? It should be appropriately specified for each outcome. Not easy to quantify. عادة كيف نعرف ال patient value and preference? What do you think? How can I know? الأفضل إنه يكون في studies. okay? To notice what does patient value and preference. يعني how much the patient value the outcome. هل إنك you prevent one clinically important bleeding for the patient matters for him yes or no. كيف أنا أعرف هذا الكلام؟ يعني عن طريق دراسات انعملت سابقا بالليترشر. okay? أو الكلينيكال اكسبرت ممكن يشاركني his experience إنه بالعيادة مثلا working with this patient and they know another we may get one patient representative يكون معنا and we took his opinion about each outcome or we ignore it, which is again the worst way to deal with this problem. What does it mean? How much variability in patient value and preference with regard to critical outcomes. What does small variability means? It's more inclined to issue a strong recommendation. إذا كان في variability قليلة بينما إذا كان في variability عالية بين المرضى usually we issue a conditional recommendation. طيب الحين خلاص already عندي evidence profile. I need to move from evidence to recommendation. Sorry, it moves. I need to consider many aspects like the quality of evidence اللي احنا already عبيناها ووضعناها لهم ال cost, value and preference, patient equity. هل إنه أنا I recommend هذا مثلا ال intervention will move shift the resources from another important intervention so I will مثلا أحط إنه affect the patient equity. Feasibility هل هو موجود everywhere yes or no. It's very important thing to consider. Risk and benefit okay of considering this intervention. طيب now خلاص we move to the stage where they need to write their recommendation. Author should indicate the strength of a recommendation. هم مو بس يعني يضعوا recommendation لازم يضعوا له strength of recommendation. بالنسبة لنا احنا we are usually following the grade approach where the grade approach عادة you have two choices either strong recommendation conditional or weak recommendation. بعض الناس يعني يشوف ان strong conditional weak يرى انه conditional between the strong and weak while it's not. okay? The conditional is a weak recommendation. Another aspect they need to state it clearly for or against the intervention or neutral either this or this. okay? It should be easy to read and understand and it should be very clear. طبعا easy scenario خلينا نقول ال benefits substantially outweigh the harm. Usually we will state in this situation strong recommendation for the intervention. Sometimes, which is the common scenario, يعني خلينا نقول the difference between the benefit and harm is not much clear. And in this situation, usually we state a weak recommendation for the intervention. What does strong recommendation mean for patient, for policymaker, and for clinician? For patient, it means that most individual in this situation would want the recommended course of action, and only small proportion will not, okay? Weak recommendation, the majority of them would want the suggested course of action, but many would not, okay? What does strong recommendation for a clinician mean? Most individual should receive the recommended course of action. Formal decision aid are not likely to be needed. What does that mean? ما أحتاج أعمل extra investigation to decide between this and this. If I have strong recommendation, support my decision, I'll give it, okay? وعادة ترى في strong recommendation ممكن يكون فيها legal consequences if the clinician didn't follow. That's why we try as much as we can to be cautious when we decide about formulating a strong recommendation. For the weak recommendation, different choices are likely to be appropriate for different patients. يعني ممكن تستخدم هذا، تستخدم الثاني, it's fine, okay? And the therapy should be tailored to the individual patient circumstances. For policymakers, بالنسبة strong recommendation can be adapted as a policy in most situations, including for use as performance indicator. The weak policy will likely be variable. ممكن تختلف تمشي مع recommendation or not. Usually we state strong recommendation in this situation where we have high or moderate quality of evidence, large benefit, small or no harm, and small variability in value and preference, low cost or resources. We issue conditional or weak recommendation when we have low or very low quality of evidence, large variability in value and preference, costly medication, and the feasibility is an issue. For our recommendation, in the question that we asked at the beginning, كان عندنا low overall quality of evidence, moderate benefit, small harm, uncertainty about the effect on pneumonia, uncertainty about patient value and preference, PPI likely more cost effective than H2 receptor agonist. So as you see, the desirable consequences will probably outweigh the undesirable consequences. We issue this recommendation. We suggest using PPIs over H2 receptor agonist for GI prophylaxis in mechanically ventilated patient in the ICU. And طبعا هذا احنا we use this wording usually when we develop our recommendation. We put between brackets conditional recommendation, and then we put the quality of evidence rating, which is low quality of evidence. I'll end up with giving just summary. For trustworthy clinical practice guideline, very important that we have an appropriate management of conflict of interest. We need to have an explicit definition of the questions, the PICO questions. Systematic review of relevant evidence is important. يعني الأغلب الأفضل إنه يكون updated. Comprehensive assessment of the quality of evidence that we get, then we make a recommendation. Always when we make a recommendation, we need to consider patient value and preference, and we grade our recommendation. When we present our guideline, should be transparently linked to evidence to recommendation. I'll end my talk with giving some nice and useful resources like the one in JAMA Evidence about clinical practice guideline and decision analysis. This is a well-known used tool for critical appraisal of guideline. And other resources if anyone is interested, or inshallah in the future he will be part of guideline development. Thank you so much.